So, Layla has decided she wants a free non-surgical rhinoplasty and has turned our entire content machine to justify her free non-surgical rhinoplasty. We'll be going through some of that process and answering your questions as we go through. I hope you find it enjoyable, and I really hope Layla likes her result. Before starting any non-surgical rhinoplasty, I will palpate the nose to see how much potential space there is within the structure. It is my belief that there is wide variation between noses, and we will get some people who simply just don't have the room for filler. And if you change the shape of the nose, you can end up compressing the capillaries and causing compression necrosis or persistent redness, which ultimately leads to requiring a reversal. I do worry that some injectors place emphasis primarily on the aesthetic result, get a great before and after, but then a week later need to reverse the procedure because there is so much redness caused by the pressure required to change the nose so much with dermal filler. I'm aiming to simplify the nose so that the two dorsal light reflexes become straight and simple and are consistent all the way along the nose. Often these reflections are the easiest way to see how to beautify and simplify a nose. Prior to injection, we have scanned the nose to look for arteries in areas where you may find a higher risk of occlusion. I'm also using a very small amount of product with each injection. By placing in a BD syringe, there is limited scope to inject more than 0.05 mils at a time. This is a very safe amount as far as avoiding our main complication, which is blindness. A very rare event, but completely avoidable when the right safety steps are taken. This needle is unprimed, making it as sensitive as possible to detect intravascular placement. This gives me some additional reassurance that filler is flowing into a place that elevates tissue rather than into a vessel where you would not get the same elevation. I'm also watching for any signs of blanching, which could indicate over-pressurizing the tissue or intravascular placement. A small adjustment after the procedure to ensure that shape is correct while I check capillary refill. You can see very small volumes are used in each adjustment, which increases our safety, but is also partly down to this being a relatively simple, low volume treatment. Above any dorsal hump is the highest risk area for vascular occlusion affecting the eyes. Most easily avoidable simply by injecting lower volumes each time you inject. A volume less than 0.085 mils should make it impossible to occlude the vessel all the way back to the eyes. I suspect in order to occlude this much of a vessel, you would actually need to inject much more than this, because a high viscosity filler does not flow easily that far back into the eye. Large volumes are likely to be associated with the blindness risk, and using a BD syringe makes sure I'm injecting very small amounts at a time. As you can see, I'm also compressing the likely position of these arteries as I inject, thus decreasing the potential ability of filler to flow back into the area we fear most. This is simple physics. Increase the pressure in the areas where we don't want filler to flow, and it will make it less likely product will go in this direction, and more likely we will end up even if we were to get a vascular occlusion, with it being superficial and easier to treat, diagnose, and prevent injury. Here you can see me carefully choosing my entry point. I look for the area of greatest curvature, but I'm also taking into account that aesthetically, if you elevate the nose superiorly rather than inferiorly, you end up with that dolphin or avatar type appearance, which many patients are aware of is not desirable. And so I'm choosing this point very carefully. You can see where that little change in curvature is. The greatest curvature is where I'm going to place my needle, aiming to elevate the tissue inferior to this point. I sense check this before injecting by adjusting with my finger and seeing if I like the aesthetic result. There's extremely little space here. In fact, on the ultrasound scan, it came to 1.6 millimeters of room. You can see I'm using multiple additional steps to reduce the total risk, and aspirating is just one of many steps I use to reduce the risk of intravascular injury. I'm compressing the area where the supratrochlear artery may emerge from the orbit, reducing the chance of filler flowing back into this area. I'm also using very small injections for each adjustment that I make. I'm deep onto the periosteum in the midline, and I've also ultrasounded this area and could not see any significantly sized vessels. So you can see me making small adjustments, always less than 0.085 mils, typically less than 0.05 mils, while compressing the nose to prevent backflow of filler. Of course, it would be possible without doing these safety checks, without aspirating, without checking capillary refill, without examining the nose, without palpating and doing capillary refill test as we go through it, that I could complete this procedure in 2 to 5 minutes. The reality is it took much closer to 15 to 20 minutes with the multiple stages. This is just how I choose to approach risk. I like to think that there are multiple ways of reducing risk, and over a career it is easily possible to get through it without causing any significant injuries to patients if you follow every step every time.